Good afternoon, everyone, and thank you for joining us for the webinar, Responding to Familiar Faces in Crisis, Part 3, Current Focus Areas and Goals. It's now 3 p.m. Eastern Time. We'll get started in a few minutes to allow for some more sign-ins past the hour. Good afternoon, everyone, and thank you for joining us for the webinar today, Responding to Familiar Faces in Crisis, Part 3, Current Focus Areas and Goals. My name is Mark Stovall, and I'm a project manager at the Council of State Governments Justice Center, and I'll be moderating today's webinar along with my colleague, Risa Hanneberg. To give you an overview of the webinar today, we'll start with introductions, including a description of the Stepping Up initiative and the MacArthur Foundation's Safety and Justice Challenge. Then we'll hear from our three sites, Bernalillo County, New Mexico, Fulton County, Georgia, and Polk County, Iowa, about their current priority areas for serving people who frequently cycle in and out of different systems and supporting this population. And at the end of the webinar, we'll have time for questions and answers from the audience. We encourage you to enter questions that you might have into the Q&A panel on the right-hand side of your screen. We're excited to have 5 panelists from the county teams with us today on the webinar. We have Margarita Chavez Sanchez, Director of the Department of Behavioral Health Services in Bernalillo County, New Mexico. Nicholas Hagney, Court Policy Analyst, Superior Court of Fulton County, Georgia. Kristen Schillig, Court Support Manager at the Superior Court of Fulton County, Georgia. Charlie Verplo, Assistant Director, Department of Behavioral Health Services in Bernalillo County, New Mexico. Maria Walker, Program Planner, Polk County Behavioral Health and Disability Services in Polk County, Iowa. And I'm also joined by my colleague, Risa Hanneberg, Deputy Division Director of Behavioral Health at the Justice Center. Thank you for joining us today. Before we get started, just a few housekeeping items to note. We're recording this webinar and we'll have the recording posted within the next 2 weeks. And at any time during the webinar, you can chat a question to us by using the QA function on your screen. We'll try to respond to the technical questions as we go, but we'll hold the content-related questions till the end for the Q&A portion of the webinar. And now I'll turn things over to Risa Hanneberg, who will talk more about the Safety and Justice Challenge, the Council of State Governments Justice Center, and the Stepping Up initiative.
Thank you, Mark. Hello, everyone. Welcome. I'm hoping that for many of you, this is you've now joined us for our third webinar working with these counties that we've been featuring. If you have missed prior webinars, certainly we can make sure that we can get those recordings to you. just wanted to share a little bit about this particular project, which is a joint project of the Stepping Up Initiative and the MacArthur Foundation Safety and Challenge Justice, or SJC. So the sites that we have been tracking their progress in working with their Familiar Faces projects in their respective jurisdictions, Bernalillo County, New Mexico, Fulton County, Georgia, and Polk County, Iowa, are both Stepping Up sites and Safety and Justice Challenge sites. So we I guess, are doubling up and taking advantage of all the great work that they are doing in both of these initiatives. Just maybe just a slight, point about the difference of the two initiatives, at least kind of the most obvious, I think, is that the Safety and Justice Challenge, the main goal of that work is to reduce all of jail population more in general, whereas the goal of the Stepping Up initiative is to reduce the number of people with serious mental illnesses in jail and across the justice system. So Stepping Up tends to focus more on that crossover with the behavioral health population, where Safety and Justice Challenge is broader. However, the sites that we are been working with in this particular project are also very focused on that population with behavior health disorders. Next slide. So the Council of Government State Justice Center, which is where Mark and I work, is a center that is a member of the largest Council of State Governments. We are like the justice arm or the justice branch of the CSG, which is a state membership organization. Most likely your state is a member of the Council of State Governments. If you would go to the website for the CSG, you would see that there are many areas of focus for any kinds of work that a state would be involved in. When you go to the Justice Center website, you will see that we are certainly that nexus, if you will, in justice. In particular, the team that Mark and I work on is that nexus of behavioral health and criminal justice, but we have other teams that are more broadly focused on criminal justice. We are a non-for-profit, nonpartisan organization. We primarily do our work around research, guidance, advising, and pushing for the work around criminal justice reform and improvements. Next slide. The Stepping Up Initiative. We're coming up on our 7th anniversary here on May 15th. Was launched to, as I said earlier, with the focus of reducing the number of people with serious mental illnesses, behavior, and co-occurring substance use disorders in jails across the justice system more broadly as well. We at the Justice Center work with 2 partner organizations in this work, NACO, the National Association of Counties. So again, as I said earlier, if you are looking at your state, you probably belong to the Council of State Governments. And for most of you, many of your counties are active members of the National Association of Counties. And our other partner is the American Psychiatric Association Foundation. So these are who we've been working with the past 7 years and pushing out and working with all the sites across the country on Stepping Up. Next slide. Another project that I wanted to share with you all today, it's just now beginning to launch, and it is coming to us through the Arnold Ventures group, and it is, some of you may be familiar with Data Driven Justice, DDJ project. Again, that is another initiative much along the same lines as Stepping Up and SJC, and this one was more focused on jurisdictions and their abilities to pull criminal justice data, analyze it, and from that make and work on improvements. So the Justice Center has been pairing up, this project now is under Arnold Ventures, to improving in particular outcomes for people of familiar faces. Some of you maybe still refer or are saying high utilizers, but the people that are coming into the justice system as well as other systems multiple times with frequency, and looking at this population. Excuse me. So soon to be announced is that there will be a statewide effort in 2 states that are going to work in this area of building out this work of familiar faces to more statewide, broader approach. And I think that's it for me.
Oh, Risa, I can cover this part. So this is the third webinar in a series of webinars focused on responding to familiar faces in crisis. So we held the first webinar on May 13th of last year, and the second webinar November 18th of last year, and we have recordings available for both of those webinars. And in addition, we also drafted 2 snapshots to really give a sense of what the sites are focused on when it comes to responding to familiar faces in crisis. And we have links for those available as well. Next slide. All right, so first up in Bernalillo County, New Mexico, we have Margarita Chavez Sanchez and Charlie Verplo.
Good afternoon, everyone. Thank you so much for having us to be part of this very critical dialogue and the series as a whole. We're excited to continue to work with Stepping Up, work with our partners at the Council of State Governments, and the MacArthur Foundation and kind of SJC as a whole. We're really excited to, again, continue our work and continue our collaboration to really work to serve the marginalized in all of our communities and those that really have difficulty accessing and plugging into services, our familiar faces that we all see in our respective jurisdictions. Next slide, please. So the Behavioral Health Initiative here in Bernalillo County launched back in 2014. And it's really important to mention that a lot of that launch happened in response to negative interactions between those living with mental illness and law enforcement. As in many communities across the country, we see this type of interaction and then an outcry from the community for change. So when that happened, when we actually, again, had a catastrophic event between someone living with mental illness who was homeless and a high utilizer of services was actually shot and killed on camera in the kills here in Albuquerque, New Mexico, the community wanted some change. So the county commission passed a tax generating funds to really be able to support those living with behavioral health needs in a different way. And this allowed us to be able to build a continuum of care, a safety net system for everyone who was having difficulty navigating care. Now, in the interest of time, I won't go into the rabbit hole of what got us to the place we were, but really talking about how we build community services to support the needs of these familiar faces and high utilizer populations. Next slide, please. Again, with the passage of that tax, it was an opportunity to have funds dedicated to behavioral health services. The most common question we get whenever we talk about the services that have built out in Bernalillo County, it's always, how do you pay for it, right? And passing a tax is something that's not a popular thing to do. But again, there was a cry for change in the community, and this was able to happen. The tax was implemented and began to collect in 2015, and we worked with CPI out of Arizona to help us build a roadmap for implementing those services. Since then, a lot has changed, right? From 2015 to 2022, a lot has changed. We've influxed funds into the community, lots of provider shortages. The elephant in the room, that's COVID, right, has all thrown us for a loop and trying to figure out how to push those services out into the community. But nonetheless, we have, again, built that continuum of care. Next slide, please. This is just a quick snapshot of the way that that system is built out. There's 4 main focus areas along that initiative. I'm going to speak about crisis services, and Charlie Verplu will speak of community support, supportive housing, prevention, intervention, and harm reduction. Again, it was really important that we had these 4 main focus areas and ways to dedicate funding along that continuum. There was a lot of push to just throw all the funds that we generated into like a big crisis triage center, a big building where folks could get plugged into services. But we knew that that was the wrong choice because we didn't just want to create another ER, right? Another revolving doors where folks would continuously accessing crisis services. The community supports, the housing and the prevention needed to be built up as well in order, again, to be able to have a full continuum. So this partnership is a partnership between the city of Albuquerque and Bernalillo County, and this brings both the city and county together along with APS, the Albuquerque Public Schools, to the table on a joint governing commission to talk about all of these issues and vet funding for proposals for funding. Thank you. Next step. So I will kick it to Charlie real quick, and then we'll kind of bounce back when we hit crisis.
Great. Hi, everybody. My name is Charlie Verplio, and I work for the Behavioral Health Initiative here in Bernalillo County. And today I'll be talking to you a little bit about our community-based services. So when we talk about familiar faces in our community and how we serve them, a lot of times we're talking about high acuity services, right? So all of those services that are built out specifically to serve high utilizers. We talk about data and data tracking in order to see where familiar faces are coming into or out of the system, right? But one component that's really important to talk about is how we address needs of familiar faces by building out a net of comprehensive services in our community. So I think that by building out these services, we can do a couple of things. One is address current needs of familiar faces in our community, right? To prevent familiar faces from becoming familiar faces in the future. And then 3, providing pre and post arrest or post-crisis, pre and post-crisis diversion opportunities. So today I'm going to talk to you a little bit about how we've built out that network of community services here in Bernalillo County. And Margarita did a great job of giving you the layout of how that funding got developed and provided for these particular services. And then I'm just going to give you a quick overview of some of how they break down into some of the things that we funded over time. So this slide describes our ACEs program, our prevention portfolio, basically. So we have our ACEs program, suicide prevention, school-based health centers, and another one that didn't make it on this slide called community engagement teams. So I'm going to briefly talk to you about all 4 of those. Our ACEs program is for at-risk families and at-risk youth, and they provide a full continuum of services, including primary prevention, identification, early intervention, support, treatment, harm reduction, etc. So we provide a whole host of services across 8 providers in order to address those adverse childhood experiences for individual families and youth that have those ACEs, or also to prevent those ACEs into the future. And there's about $3 million allocated for this particular initiative. We also have suicide prevention programs that funds 3 providers in our community. We knew that suicide was a really difficult and really complex social problem that faced residents here in Bernalillo County. And so we wanted to first understand the factors like mental illness, substance use, violence, isolation, all of those things that go towards the prevalence of suicide in particular communities, and then work towards contracting with providers who could work to prevent that as a social problem. So they provide training, education, and services in order to address this effort of suicide prevention here in Bernalillo County. We also have a really neat initiative on school-based health centers. So many of you probably hear about school-based health centers across your communities. And what we've done here is we're going to be putting some money towards the development of 2 school-based health center units. And then those units are big medical RVs that are going to go to a variety of different locations in Bernalillo County across our APS school system and our charter system in order to provide primary care, health care, reproductive services for kids in need, for youth basically ages 0 to 18 across that system of care. And so we know that sometimes youth and families have a really difficult time accessing healthcare and primary care and behavioral health care when they're in school, because it's difficult for our parents to leave work and things like that. And so be able to provide those services right there in site really mitigate some of that issue of access to those types of services. And then lastly, I want to tell you about our community engagement team. So we have allocated some money to a peer program that provides intervention both pre and post crisis to families in community. So we go out to community to where people live and engage them prior to being in crisis and maybe after they're in crisis to be able to provide those peer services to engage individuals and connect them to longer term services. It's a brief intervention, maybe 4 times at max of touching that individual, but the intention is that they engage them in more long-term, maybe supportive housing, maybe there's need for social service connection, maybe there's need for something as simple as an ID or medication connection. So we work through all of those services and connecting clients to what they might need. Next slide, please. The next slide goes through our community supports services that we have. So we have some peer drop-in centers, some peer case management, and a living room model that we're just starting. So our peer support drop-in centers, they're basically community drop-in centers where individuals can come who have behavioral health needs and engage with someone else who might be living with a behavioral health need. So substance use disorder or mental illness, and has moved towards different stages of recovery so they can be supportive to those who are still in the early stages of contemplation about change or engagement with that particular disorder. Recovery services are provided by peers who have that lived experience, creating an environment where members have an opportunity to engage in healthy, life-changing recovery efforts. Our peer case management program utilizes peers as well, and they work as part of a team to provide case management to those who have behavioral health needs in our community. And then finally, our living room model. So the living room model also works with individuals who are pre and post crisis, who have a behavioral health need, and uses peers to do that with some clinical intervention. And it's a little bit like a drop-in center or a clubhouse. The intention behind the living room model is to be exactly that, a living room model with a really comfortable space, potentially some couches and maybe some food provision and engagement with individuals so that they can feel comfortable, trust the service provider, and then engage in longer term services without having to utilize a higher acuity, higher cost service like the emergency room in order to navigate that particular behavioral health need. Next slide, please. And then lastly, and I'll try to wrap this up quickly. So, we're on to crisis. Sorry, I'm going to turn it back to Margarita.
Thank you. Sorry, we bounce back and forth a little bit. So again, as I mentioned, one of the 4 main focus areas is crisis services. So these, again, are going to be a lot of the really high touch points for our familiar faces. We launched our mobile crisis teams. Again, this is a collaboration between the city and the county. We have a total of 6 mobile crisis law enforcement-based teams that pairs either an officer or a deputy, officer from the Albuquerque Police Department or a deputy from the Bernalillo County Sheriff's Department with an independently licensed master's level clinician to respond out of the 911 system to behavioral health calls. These teams really work to provide a new resource to law enforcement to respond to those behavioral health calls. So again, as I mentioned, that very public negative interaction between law enforcement and someone living with mental illness, this again is providing law enforcement with a new tool to bring a more appropriate resource to those scenes. We really do see familiar faces hitting the mobile crisis teams. The data shows us that there are a number of reoccurrent calls from reoccurrent addresses. And fortunately or unfortunately, right, many of our clinicians are actually establishing a better rapport, right? Our clinician and our clients on the mobile crisis teams are gathering a better rapport than they would in a traditional hospital-based or community-based setting. So what we're having an opportunity to do now is those clinicians are establishing that rapport and trust and having a clear, warm handoff to those community-based services so that they are taken there with somebody who they believe is an ally and then really working to connect in that way. We have also launched 2 fire mobile crisis teams. So these are non-law enforcement teams because we do believe, right, that not everyone living with a behavioral health need is warranting of a badge and a gun responding to that scene. And so a fire mobile crisis teams allows for a continued first responder response out of the 911 system, but it also brings a paramedic to the scene, right? That paramedic can also provide a physical assessment. It's not uncommon for someone who's having a diabetic emergency to maybe present as if they're having a psychiatric episode, but a paramedic can assess if it really is a diabetic emergency and needs a different type of physical response. So that team is also providing additional asset in the community and really working to mitigate those 911 or crisis system calls and connect folks into the community. Our Resource Reentry Center, if you've seen any of these other webinars, you've heard a lot about our Resource Reentry Center. This is a partnership with the county and the University of New Mexico Hospital. University of New Mexico Hospital has transition planners who are located within the jail, and all clients who are discharged from the Metropolitan Detention Center here can then be released to the Resource Reentry Center as their soft landing back into the community. So from this picture, you can see the intention is for it to be non-criminal justice, non-clinical, non-traditional, like non-correctional, like really just a comfortable space. The thought around the colors of the walls and computers that folks can access, phone charging stations. I'll say it, I'm sure many of you, if you've again heard these webinars, you've heard me say it before, but it's really like the gift shop, right? You think the jail was the ride that you were on at Disneyland, right? You're on the Small World in jail. You get off the Small World and right away you're into that gift shop. So this Resource Reentry Center is that gift shop and an opportunity to connect to services, get some coffee, get some food, sleep overnight if you need to. Our crisis stabilization unit is also a great program here. We're licensed as a crisis triage center. We have a 16-bed, 14-day inpatient crisis stabilization unit. Many of our referrals to this unit are folks that either go to the psych emergency room and don't meet inpatient criteria, but not quite comfortable with them just going home. They can come to stay with us for 14 days, or someone who has already been inpatient and has stabilized, but they need a little bit more stability before they just return home to care for themselves or with their family. So it is a soft landing, intermediate level of care. And we have really seen success in this program with people who go to our detox service and then transition to crisis, right? So they get those substances out of their system, address drug-induced psychosis first, and then can move into our crisis and stabilization unit. So really, these are big front doors for our familiar faces. And at the Resource Reentry Center and the Crisis Stabilization Unit, we have, anytime somebody does an intake on either of those places, we can screen and see if they are one of our familiar faces and immediately wrap around them with services and plug them into care and out of those high cost, high need systems. Next slide, please.
So back to me, I'm going to give you a quick breakdown of some of our housing programs, and really interesting to cover those crisis services and the ways that people are that biggest front door where these familiar faces are engaging with services. And then the next steps that you need to do once someone is stabilized, not in that crisis situation any longer, and needs a place to be longer term to be able to recover and navigate those longer term needs. So really that's where you come against some of your housing needs and community. And I think probably most communities across the United States are navigating just higher needs around housing and increased costs for housing. And so that's not unique to Bernalillo County, and we're finding new and unique ways to be able to address that particular issue. So there's 4 programs I wanted to highlight for you today. One is our scattered site housing program, which is a jail reentry and frequent utilizer supportive housing program. So it does address this particular familiar face population. And it's a program that provides scattered site housing with a voucher for a particular apartment complex, along with intensive wraparound services from contracted providers in order to support individuals who are homeless or precariously housed with mental illness or co-occurring disorders to navigate those needs and also remain housed and be successful in that housing. We also learned that not everybody is extremely successful in that scattered site setting. So they might need a little bit more acuity, higher acuity service beyond just connecting with a case manager maybe twice a month. And so we decided to work towards building out 2 single site supportive housing complexes. So these are large apartment complexes between 40 and 60 units, and they have on-site services for individuals who are homeless or precariously housed. They have a mental illness or a substance use disorder, and they have significant behavioral health challenges that have made it difficult for them to be successful in other types of housing dynamics, right? And so being able to develop such a situation where you have very intensive wraparound services, these individuals who are probably frequenting through or recidivating through particular services like the jail or the emergency room, being able to intervene in that moment, provide housing, and then provide really intensive wraparound services so people can be more successful with their housing, and the stability of their housing is the intention of this program. We also have some youth transitional living services programs. So we know that the population between 18 and 25 sometimes has a difficult time in that transition between youth and adulthood. A lot of times social services are sort of phasing out at that time in life. And so being able to provide that extra support to those individuals as they transition into adulthood and help them to be successful and not become frequent utilizers later is really important. And so these services provide services for at-risk youth who are precariously housed or homeless and have a behavioral health diagnosis. The funding provides youth transitional service for housing for clients, but also other types of services, wraparound services for individuals so that they can be successful in the housing that they're in. And then finally, I'll mention our tiny home village. So we just are starting this program again. We're starting to bring in clients. This is a transitional housing program that helps individuals who are, again, precariously housed, also have a behavioral health need, and helping them to be housed for a certain portion of time, get their feet under them, work with a case manager, work with a medical provider, get their needs met, and then work towards longer term permanent supportive housing within 6 months to a year of their being housed within the tiny home program, and being able to transition more clients into that program as those individuals phase into their longer term housing. So I think that those are all the slides that we have, Mark. So I just wanted to thank you all for listening to us, and yeah, we'll stick around for any questions that you might have for the way that we've developed out our system in Bernalillo County.
Perfect. Well, thank you so much, Charlie and Margarita. So now I'll turn things over to Nicholas Hagney and Kristen Schillig in Fulton County, Georgia.
Yes, thank you, Mark. Hi, everyone. I'm Nick Hagney. I'm a court policy analyst and a statistician with Fulton County Superior Court. We have kind of a two-part presentation. I'm going to go through our data journey with Stepping Up and our familiar faces, and talk about where we started, where we are now, how we use our data, and where we hope to go to in the future. And then Kristen is going to talk about our diversion center. So next slide. So initially, when we began this work around familiar faces, we started off as Superior Court employees with our county criminal justice data management system as our primary source of information. This is where we capture all of our booking information, our cases, the dispositions on those cases, information about the individuals who are in our jail and wrapped up in our legal system. Odyssey is a huge data system, and I'm not aware of how everyone else's jail management systems work, but ours is essentially like a lookup tool. Case managers, public defenders, pretrial officers, they need to know a booking number or a case number. They need to know an individual's exact information so that they can look them up and find, whatever information that they're looking for. But it does, previously, it didn't have a good way of pulling out information in bulk. It was hard to do aggregate analyses. And it was time consuming, because if you're a case manager or a social worker trying to get a handle on a whole lot of people's cases, then you had to go through one by one, look everything up, and record that information. So we are lucky that our Odyssey system is operated by the same company that operates Socrata, which is a data dashboard and visualization platform. So this allowed me to build some data dashboards and some data assets around the jail, around our court cases, so that information was much easier to pull and to tailor for specific needs. Fulton County also operates a database for our Department of Behavioral Health, which contains the results of all of our mental health screenings that are performed at our jail, which is then linked back to all of our Odyssey data, and then can then be visualized and set up in our Socrata platform. So this is how we've built dashboards related to Stepping Up and those key measures. This is how we track our familiar faces population through dashboards on Socrata. And this is also where we just host a lot of data that can then be pulled and used for our, various projects or various like efforts that we are taking around our population that has behavioral health needs, that are housing insecure, that have substance abuse issues. And so like some examples of the way we use that data is that, first thing every day is I get a updated list of everyone who is in the jail. And I can cross-reference that with our list of familiar faces to send out the appropriate updates to partner agencies so that we can begin resource and service planning at booking so that we can begin reentry planning. But I also get all the information related to everyone in the jail who has screened positive for a mental health concern, which relates to our reentry work group, which I'll talk a little bit more about in the next couple slides. We also, use that data to immediately identify a case once it's been indicted, and we know exactly what charges are attached to that case. We can look at the schedule for upcoming hearings so that we know that personnel can be allocated appropriately. Into the right courtroom and in front of the right judge. And we also know about bond information related to any of those charges, because we are also plugged in with the bail project in Georgia. We've done some analysis around technical violations. And the way we define technical violations are people who have violated a probation condition or a pretrial condition, but have no new charges attached to them. So we've just done some aggregate analysis around that over the last several years. We're also building capacity around warrants, which relates to our diversion center. But this has been difficult due to the fact that we have a small but significant population at the jail who are booked for foreign county warrants. And so, I'm a Fulton County employee. I don't have access to, criminal justice data from jurisdictions outside of Fulton County. So that sort of ties into our data sharing project, which I will also get into as I go through these slides. So next slide. Here are a couple screenshots from our Stepping Up dashboard. Our Stepping Up dashboard is not publicly available, but we do publicly report on the information contained therein. This is only available for Fulton County employees. And it does host like individual level information, which is why this particular like iteration is not public, but we do report on this, and we are going through like a website migration renovation right now. And so we are going to be having that kind of like aggregate reporting hosted on our website soon. But so these dashboards are really great for drilling down into like granular level data. That top graph is just looking on a day-by-day basis how many people were booked into the jail by their screening status. In the lower, the two bar graphs below, those are demographic breakdowns about the average length of stay by screening status. And so you can see that for men and women, regardless of whether you're a man or a woman, if you screen positive for mental illness, you have an average length of stay that is longer. And so, like I said, this is from our Stepping Up dashboard. So this data has all been tailored to our Stepping Up key measures. But it also allows us to look at individual cases. And it also allows us to do retrospective analysis, look at time trends, and just report on how things have changed since we started collecting the results of these mental health screens. And you know, I addressed it on the last slide, but like there's a lot of data that we have that doesn't fit well in a dashboard. You can't visualize it very well, but we have live data feeds available about, you know, cases or hearings that are available so that we can quickly pull information on a group of people and make it available to the agencies that need it. Next slide. And so just to kind of like illustrate our jail and, you know, talk about how we use our data to identify service needs. So we have a reentry work group that is tasked with providing reentry plans and appropriate programs and services to all individuals who screen positive on our mental health screen. And so with our dashboards and with our data feeds, we're able to, you know, easily identify every day, every week, every month, like who in jail has screened positive, what are their charges, like, so are they appropriate for a reentry plan? And then we can, you know, we bring that list of people essentially to this reentry work group that goes through all the nitty-gritty details of setting up what that reentry plan is going to look like. Over the past couple of years, we have sat at about 17% of our bookings are for individuals who screen positive. And about 85% of our jail actually gets screened. I mentioned it earlier, but we do have a portion of our jail population that is brought in on like a foreign county hold. So they don't become eligible for screening because they are simply booked into the jail, held for a brief period, and then transferred to the appropriate county or jail facility. Next slide. So, you know, just continuing in that vein, you know, we use our live data feeds and the linkage to those screens to track individuals over long periods of time. So like we have our identified familiar faces cohort, which we're very, you know, concerned with, and that we have all this, you know, planning and work around. But we also have individuals that we would like to be defined as a familiar face, but don't have the legal system involvement thus far to kind of like trigger or to meet the conditions to be slotted into that familiar faces group. But having this historical repository of information and the results of, you know, their mental health screens going back, we can build criteria to better capture individuals who do have high needs, but may not have been identified in an initial or secondary analysis. But as they come back into jail, we have that historical information to say that, okay, this person is appropriate for this group and does need more intensive care, attention, service planning. And like I said, you know, our reentry group focuses on staffing all of these cases and putting together reentry plans. And just to broadly describe that group, it consists of our legal partners, such as like our public defender, social workers office, pre-trial, but it also community stakeholders. So our pre-arrest diversion initiative, Grady Health Systems, which is our safety net hospital in Atlanta, and our county and city homeless providers. So they are all part of these groups, all working together to appropriately serve this group of high need individuals, our familiar faces, but also everyone who needs it. And some of the things we currently have cooking, we're trying to implement a housing screening in jail. We know that housing is like our biggest need and the thing we have the least of. So having that baseline information would be, really great for us as far as demonstrating need. But we're also very focused on a data integration project. Everything I've been talking about has been focused on the criminal justice system because that is what, as court employees, that is what we have direct access to. When we first identified our pilot cohort of familiar faces, we cross-referenced them with a number of systems from our Grady Hospital to our homeless providers, looked them up in HMIS. We cross-referenced them with Atlanta Police Department data. And we got a pretty good view of their utilization of our local systems, but that was done, we had to send out a list of our familiar faces. We don't get that information just on an automatic basis. And in Fulton County, in the city of Atlanta, our data systems don't speak to each other. All of this information is siloed. And it sort of just means that agencies don't work as well together as they could. And so that is kind of like the impetus for our data integration project, which we then see as being like a stepping stone to a broader case management framework and software for our Center for Diversion and Services. So next slide. So the data integration project, this was the #1 recommendation from our Fulton County Justice and Mental Health Task Force. I just said our systems don't speak to each other and there hasn't been good coordination of information previously. So our initial concept is just a very basic data sharing software that we hope to scale up as we demonstrate the efficacy of. But the initial system would just really be my favorite way to describe it is a resource phone book. So an individual consents to have their information shared amongst participating agencies. And then anytime that individual shows up at the jail or the hospital or pre-arrest diversion or one of the homeless providers, an employee or a caseworker at those entry points would be able to look this person up and they could see this is the program or service or caseworker that this person is connected to. Let me just make a phone call and get them re-engaged in this service. Because this is even as simple as that is, it's not something that we have had previously. And ultimately the goal would be to really ramp up that data sharing to make it a lot more comprehensive and a lot more useful and fit into everybody's day-to-day easier. But since agencies are very protective of their information and rightly so, they are hesitant to, fully dive into fully comprehensive data sharing. And instead, we want to take the appropriate kind of baby steps to get there. And next slide. And so currently we are, this is my last slide and I'll turn it over to Kristen, but currently we are conducting bi-weekly meetings with all of the participating agencies, where we're working through a data sharing MOU, as well as a universal release of information. Our county attorney's office is leading that work. Actually, a big thank you to Bernalillo County, because they provided us a rough draft of the MOU that we have really like taken and run with and built off of. So that, you know, that helped get us to a starting point, and then we have adapted that for our own needs. Our technology partner, Tyler Technologies, they have built a mock-up of this data query tool and have been hosting feedback sessions from potential users. And then right now we are drafting like a standard operating procedure, as well as some evaluation metrics, so that we can, you know, once this is in place, we can have, everybody knows what they're doing, and then we have a way of measuring success and, you know, demonstrating why we need to go further with this work. And that is it for me. I'll turn it over to Kristen to talk about our diversion center.
Thanks, Nick. So good afternoon, everyone. My name is Kristen Schillig, and I work for Fulton County Superior Court and manage the Fulton County Justice and Mental Health Task Force and our Familiar Faces project. So very happy to be here today. So today I'm going to talk you through a new project that we've been dreaming of for many years here in Atlanta and Fulton County. During some of our initial Stepping Up planning meetings in 2017 and up until mid 2021, our stakeholder group has been asking the question, divert to what? So meaning besides the county jail, city detention center, and our safety net hospital, Atlanta has no dedicated location for law enforcement to drop off people experiencing mental health and substance abuse concerns or extreme poverty. Next slide, please. Multiple initiatives have generated momentum for an alternative to jail for people in need of services and care and not incarceration. So the Fulton County Justice and Mental Health Task Force began convening and organizing around Stepping Up in 2017. During that same time, the Reimagining Atlanta City Detention Center Task Force convened to dream of ways to repurpose the city jail that has sat mostly empty for years because of reforms around bail practices during our last mayoral administration. We also recently participated in a SAMHSA community of practice to get ideas on strategies and solutions in Intercept 0 and Intercept 1 space. So we came up with the concept using many different ideas and strategies from our various groups and planning efforts to use the mostly empty city jail as our pre-charge law enforcement diversion center, or our divert to what? Next slide, please. So creating somewhere to go advances the city and county goals to reduce the use of jails as crisis centers. We have analyzed a lot of jail data to define our problem that helped make our case to our elected leaders. And we've listed some of our key data points here. So, and I will quickly go through those. 22,000 or more people detained at the Atlanta City Detention Center between 2017 and 2020 were held for charges associated with homelessness, mental illness, and substance use. So it's about 30% of bookings. Since September of 2019, over 8,000 bookings at Fulton County Jail have been for individuals who have screened positive for mental illness, or about 18% of all bookings. And the average length of stay for people with mental illness is 64 days compared to 41 days for people who don't screen positive. And then 10,000 or more Fulton County bookings between 2017 to 2019 were for low-level charges associated with homelessness, mental illness, and substance abuse. So we're talking lots and lots of people. And so we just know we can do something different. Next slide, please. So you might be asking yourself, a jail, right? So how does this make sense to use a jail as a services and support center? And really, it's just about the location. So through our data analysis, we know that many of our arrests for what we feel are eligible charges happen right in downtown Atlanta. So the city jail is right in downtown and in a strategic location. It's a very large, huge building that the city owns that is, again, mostly empty. So the diversion center will occupy about 8,000 square feet and will be separate from the corrections activities. It will have a dedicated entrance with easy drop off for law enforcement, which is very important. There's also some potential for use of outdoor space. And then you can see in the picture here in the little, in the bottom left-hand corner, that's the kind of the side of the jail where this diversion center will be. And the diversion center is actually the space that's in brick. So if you're on the street, it actually looks like a totally different building. So anyways, it's kind of like a little glimpse of what our center will look like. Next slide. All right, so it's important to highlight how many people we think we can divert from both the jails and the hospital. And we do see our familiar faces as a primary customer of the center. So we are just very excited about the support the center will provide and are anxious to start redirecting people from these jail responses. So as you can see from this slide, we think that there's a potential to divert over 10,000 jail bookings and over 4,500 police custody admissions from our safety net hospital. I just want to emphasize, like, our emergency room, obviously the hospitals have been in crisis with COVID and just all the things, right? And so this center, I think, will provide that sort of diversion from our hospital, which is just super critical right now. Next slide. All right, so what is the Center for Diversion Services? So it's a law enforcement drop-off center with co-located services and connections to additional resources. So our co-located partners include Grady Hospital, which is our safety net hospital, the Georgia Justice Project, and the Policing Alternatives and Diversion Initiative, which manages our lead project here in Atlanta. And I've listed some of the services we've identified, and I'll just really quickly run through them. So the center will offer a quick and efficient drop-off for law enforcement so they can quickly get back on the street. We'll have screening and needs assessments conducted by our various co-located partners. We'll have a sobering center where police can drop people off who just kind of need to sober up. We'll have peers throughout the center operations, providing support and referrals. Also want to note just about our peer network here in Georgia. I mean, Georgia does a really good job with our, we have the Georgia Mental Health Consumer Network and the Georgia Council on Substance Abuse, who have really provided us a lot of just critical feedback and support through our planning process. For those of you kind of getting into this sort of work and planning these sort of centers, I just highly recommend including the peer community in that planning. We will have staff that can conduct housing assessments and placements. Our co-located partners will provide case management, legal aid, and non-emergency medical care. The Georgia Justice Project will be providing warrant resolution, and y'all were pretty excited about this warrant resolution stuff. If you didn't notice, Nick also mentioned it in his presentation. So the Georgia Justice Project will be providing this kind of warrant resolution service, which we are still developing. But as many of you probably know, having an active warrant is a barrier to diversion. So we just feel like this is a very complicated problem that many folks face. So we're just really excited about the potential for this type of service to just really increase diversions and increase the use of the center. And then finally, the center will have amenities like pantry, laundry, showers, MARTA cards. We're building out like a little living room space and meals. And one of the other benefits of having this at the jail is that we already have a commercial kitchen built in, and then just lots of sort of things that help make the center, ready to go. Next slide. So just quickly, some of the goals include providing a service-based response to people with mental illness, substance use issues, and chronic homelessness, reducing the number of people with mental illness and substance use issues in jails, connecting clients to services, and preserving law enforcement and medical resources. And then obviously we want to try to build out a full continuum of care over time to serve the Metro Atlanta area. We really do think the center is just kind of a first step in this continuum, and it's just really exciting to get this group of people together to start, building out our dream, and maybe someday we'll be like Bernalillo County, which is, you know, they're the superstars there. So anyway, so very exciting stuff. Let's see, next slide. So some milestones to share. I won't read through all these bullet points, but I do want to highlight this first milestone. So in November of last year, a formal intergovernmental agreement was signed between the City of Atlanta and Fulton County. This is a significant partnership between the city and county that details a formalized funding structure and commitments, and it establishes a justice policy board that oversees the center development and operations. So really, really important work to get the city and county on the same page and committed to funding and just making this go. And they have consensus on the concept. It's just really, really exciting. And then also worth noting in these milestones is that, you know, our collaborative work has attracted funders to the project. So we've received some support from the Georgia Power Foundation and also the Microsoft Justice Reform Project. So, you know, when you collaborate, it brings money. So, yeah, and I think that's the end of my slide. So, so just to wrap up, you know, thank you for letting us share our data work and on this new Center for Diversion and Services. I know that many on this call understand that these types of projects take a very long time with lots of hurdles and setbacks. And really what we've learned is that collaboration is absolutely critical to build services around familiar faces. For this to work, we've just got to work together, get creative. I mean, obviously we're building a diversion center in a jail, so we're creative types here, and just thinking outside the box and just relationships, right? And stay committed. So thanks for the opportunity to share. And I will put my email in the chat if anybody wants to connect or has any direct questions, and I will pass it over to Mark. Thank you.
Great. Thank you, Kristen, and thank you, Nick, for your presentation. So now I'll turn things over to Maria Walker in Polk County, Iowa.
Thank you, Mark. Good afternoon, everyone. I'm Maria Walker, Polk County Behavioral Health and Disability Services. Today, I'm going to talk a little bit about our workforce strategic plan that we have. I think that I'm preaching to the choir when I say that we are in the midst of a chronic shortage of human service professionals across the continuum of supports and services within our behavioral health systems. We have a comprehensive plan to address all levels of staff and all of the various complex issues surrounding the shortage of the workforce within our human service field. But today, I'm going to talk a little bit about our initial efforts at our frontline workers. There are direct support professionals, direct line staff. They're the long-term services and supports types of staff. Just to give you a little context of who it is I'm talking about staff that provide direct supports and services within our assertive community treatment teams, our forensic assertive community treatment teams, all of our hourly and daily home-based habilitation services, all of our RCF, PMI types of supports and services, our supported employment services, just to give you a little context of the type of staff that we're focusing on today. Next slide. Whoops, next slide. Sorry, I forgot the first one. This is kind of our why, Polk, and this is our Polk sense of urgency. In the Iowa Code, the regions, just to give you a little idea of how Polk or how Iowa is operating. We are a regionally based system in the state of Iowa. It's typically anywhere from 3 to 15 counties that partner to form a region. In Polk region, we are a county of 1 simply because of the urban population within a very rural state, if you will. So what Department of Human Services in the state of Iowa dictates is that the region have access to services within specific timeframes. You'll see with some of our long-term supports and services, our home-based HAB or supported community living, our supported employment, our long-term service coordination. There's some exact access guidelines that need to have. And quite honestly, we're not meeting them because of the large vacancies of our workforce. You'll also see some of it, just for reference, our crisis service access requirements. We know that if we don't address our long-term services and supports, we're really hampering the recovery of our community individuals that we're supporting. We're facing larger backwards congregate institution settings, and then a longer never-ending cycle of crisis. We want to get people beyond crisis and into a state of recovery. Additionally, with this is new for the state of Iowa. The regions have entered in with the state of Iowa performance-based contracts. So any incentive money that is sitting there that we can get access to, these access to service requirements are part of our performance-based contract. So that's really putting in jeopardy the incentive money that we could have access to. And quite honestly, when we talk about incentive money in the state of Iowa, we're talking about really needing this just for stability and maintenance of our current budget, let alone growth within our system. Next slide. This is our second reason for focusing on our direct support workforce. This is our data that says the why of why we want to focus on long-term supports and services. Just to give you context of this graph, this is a group of individuals that we have been supporting that are high utilizers of our jail system. We know that when we focus on employment, education, community inclusion, and safe and affordable housing, the percent of what we call our good events or our good outcomes, our jail days, our ER visits, our homeless days go down. So this is kind of our second why, because we know this is the right thing to do to help folks get on that recovery level of their life. Next slide. This is kind of an overview of the strategic partnerships that it's going to take. It's going to take a village, and this kind of shows what we're doing in the grander scheme of our strategic plan. But we know that it's going to take the Department of Education, our community colleges, our local school districts to help create a talent pipeline for direct support professionals, as well as for those wanting to go into social work and other degree programs. Health and Human Services, we know that they're very important in terms of Iowa Medicaid, the Iowa Department of Public Health, our providers and associations. We're trying to hold our providers as whole as we can and to help them. We have a very good relationship with our providers and believe that our system is only as good as our providers. And quite honestly, only as good as our direct support workforce. We also know it's going to take workforce development, our Greater Des Moines Partnership, which is our local chamber. And then there's a lot of policy issues that need addressed with our Iowa legislators, our federal congressional leaders, our county supervisors, and our taxpayer association. And you might think, wow, typically those taxpayer associations are on the opposite side of legislation with us. But we felt like, and I'll talk a little bit about administrative burden or red tape, who better to sit on the legislature than reducing administrative burden so that we can put the money towards the direct support services and reduce all of the documentation and things that take away from working directly with an individual. Next slide. Some of the early identified opportunities that we've seen is to professionalize the direct support workforce. We explain in a couple of slides why we need our own standardized occupational code, but that is key to increasing the rates that are needed to sustain livable wages. Iowa has one of the most restrictive Medicaid documentation requirements nationally. There's studies that have been done that showed that back in the good old days, you would have 80% direct work with individuals in our system and 20% documentation. In many of those direct support roles, including coordination, that has flipped, where it's 80% documentation and 20% working directly with clients. That has to change. And quite honestly, our state is addressing it. It's probably one of the biggest things that we can do to help reduce the burden for people with direct support professionals. It also widens who it is our target can be for recruiting our workforce, including immigrants. We also know that we need to attract the right workforce, and we need to address the compensation rates, as I noted earlier. Next slide. Direct support professionals, they really are kind of a big deal. They are the ones that provide person-centered supports for people with complex needs, multi-occurring diagnoses. They support the whole person in all facets of their life. And I'll show you on the next slide what we mean by that. The demand for direct support professionals is increasing. We have an estimated 900,000 FTEs now. I believe that is low in terms of the numbers, particularly when it talks about all people with disabilities and people with behavioral health needs. There aren't good studies that combine both of them to show what the full direct support professional need is. And the problem is that it's not recognized by the Federal Bureau of Labor. There is no standardized occupational code. And the reality is it's primarily funded with Medicaid waiver dollars, which we all know have very low rates, and they just don't allow for adequate pay, which just compounds being able to attract a workforce. Quite honestly, a lot of our staff, the reality is they themselves are on public assistance because of the rates of pay. Next slide. This kind of shows a crosswalk that was done by the National Alliance of Direct Support Professionals. It shows the competencies that are needed to be able to be a direct support professional. So you're talking about health and safety, vocational educational career development, crisis prevention and intervention, documentation requirements. And then what they did was they aligned this with other positions, nursing assistants, home health aides, personal care attendants, and they even did a crosswalk with LPNs just to show how complex it is and the competencies needed to be a direct support professional. So that kind of gives some context of the need for a separate standardized occupational code, because the reality is all of these people, with the exception of LPNs, are lumped into one category that's recognized by the Bureau of Labor Statistics. Next slide. This is our solution and our reason why. Our why is our providers, it offers an online option to gain certification based on demonstrated competencies. It's nationally vetted competencies. Quite honestly, the NADSP competencies are the Medicaid services core competencies, along with the Code of Ethics. And it's the only long-term services and supports approved training curriculum recognized by the Department of Labor. That's a pretty rare thing to happen, particularly when we don't have a separate occupational code within that. It's flexible enough, and I'll talk a little bit about the how it works, but it's flexible enough to add competencies important to us in Polk, as well as anywhere else in the nation. For instance, it's important for us to be inclusive of multi-occurring training. It's important for us to include positive behavior support philosophy and tools such as motivational interviewing. The e-badge is research. So it's a type of training that's online where you're gaining small badges for small training components, if you will. There's been research that shows that it works well. It's actually working in secondary, post-secondary businesses that have training standards. and it's moving towards this model of training. You get gratification for badges in small increments, and they see that that's really motivational for the learners. The badges themselves are mobile and nationally recognized, and these certifications actually stay with the learner. So what mostly is happening is it's upon the providers themselves to have training developed. There's some online things that work, but when somebody leaves, or if I were to move into New York State, for instance, I wouldn't have any kind of training and certification, even though I have a lot of experience from my current employer. So this is a mobile badge certification event that is becoming nationally recognized. And the big reality is we're not able to get people into training seats. You know, there's a huge value to have people face-to-face to promote that networking and shared learning, but that's not our reality. We can't even cover current shifts for our long-term supports and services. And so it's really important that we be able to provide just-in-time training and training that works within schedules, particularly when the reality is a lot of our direct support professionals are working minimum 2-3 jobs, and as well as have families, many that have other socioeconomic issues that are complicating their lives. Next slide, please. The nice thing about the National Alliance for Direct Support eBadge Academy is it comes with a management information system to track where learners are, the badges that they've earned. Actually, thanks to New York State, who's infusing $10 million of their ARPA money into this system, the system will get an upgrade for even enhanced tracking, which is probably going to be needed as nationally it becomes more of a recognized system. It allows own training curriculum through a well-established training program. They have to accredit trainings that you can apply towards your badges. Providers can maintain or obtain that accreditation. There's nationally known online such as Relias and College of Direct Support. We became accredited with our frontline supervisor training. So there's it allows for those that it's not just one fit meets all, so you can customize it yourself. This works well for us to manage on behalf of our network providers. It means that our providers can do what they need to do in terms of making sure the delivery of services are there. It allows us to then do that on behalf of our network of providers. We believe the competencies have legs to become the standard of training once that occupational code's established, and there is a movement to standardize training curriculum. Next slide. Another RY is the numbers don't lie. Nationally, there's some pilot projects that have been happening, and you will see the reduction in turnover, which has been pretty significant. We did a survey, and there's nationally been surveys of direct support professionals who really do want additional training to become more competent in the job that they do. And so we believe that the reduction in turnover is significant enough for us to work on this initiative. And that's it. Thank you, everyone.
Thanks, Maria. And now we have a little bit of time for questions and answers. So I'll turn things over to Risa to moderate that section.
Hi, everyone. I'm back and recovered, I think. So we are sort of short on time. I just want to do a couple things. First, I'm going to give just a little bit of a tease. This is our third and final webinar in our work focusing on familiar faces. And I know Mark and I have worked closely with these 3 sites now for 2 years, and just been a great experience watching them as they grow these programs, and so much growth. And as was said earlier, during a pandemic and when all kinds of issues were being faced that you never would have imagined. But we are, fingers crossed, thinking that we will be back with a different focus, again, spotlighting crossover work between Stepping Up sites and SJC sites. So looking forward to hopefully being able to announce something maybe later on in the summer. Also coming still as a result of this particular project is one more point in time reports coming out probably here in the next month or so. I want to wrap up. I want just some quick questions, some final with our panelists today of our 3 sites. I know, Kristen, you said that, I think you said that if you had to say one lesson learned throughout all of this work, it was the importance of collaboration. And so I just want to ask if anyone from Bernalillo or Maria from Polk, if you, in just a word or two, what is your biggest lesson learned so far in your work with the familiar faces population?
I'll go quickly, Risa. I think I would agree collaboration is key, and ensuring that we have those with lived experience who are our familiar faces and those that are navigating the system at the table, right, to plan and coordinate, because we think we know it, but we really don't, right, is really having kind of those populations we serve at the table with us. So just expanding on collaboration to really include those with lived experience.
Thanks. And Charlie, did you want to jump in for Bernalillo?
Yes, I was thinking about the capacity to share and integrate data across providers and across networks, and the difficulties related to ensuring privacy for clients and providers, and so that they can build trust with the clients, and then also the ability to ensure that we can kind of understand where people are in the system, how to best serve them. So I think that's been a really difficult thing, and something that Margarita's team and Pamacosta have been working really diligently on here. And I know the other jurisdictions are working on that as well, considering the presentation. So I think that that's where we're headed, is to do better in that area, and to put, some funding towards things like that, to be able to make sure that those integrated systems can go into the future.
Thanks. Maria, anything you want to add here?
Sure, I think I'll piggyback a little bit off of what Margarita talked about in terms of people with lived experience being a key component of supports and services. I was remiss in talking about this, but lessening the documentation requirements really helps engage those with lived experience to have a larger role as it relates to direct supports and professionals. And so we are really excited, because we also believe that for people with mental illness, as well as people who have a developmental disability, being able to engage them into the workforce and supporting that.
Thanks. And Nick or Kristen, anything else to add on lesson learned?
For me, I would just say taking stock of your data landscape in your jurisdiction is really important, because we have found over time a lot of stuff that we wish we could have gotten started with when we first started this project.
Thanks. Kristen?
I would just add, just thinking through a communication strategy, I think is really important. With the familiar faces, obviously there's lots and lots of arrests, which gets kind of tangled and confused with some of the narrative around, violent, offenses or repeat offenders, and they're two separate, they're kind of separate things. So just thinking about, like, with your stakeholders and partners, like how to message like the familiar faces work, because, for us, our familiar faces have lots and lots of arrests, but we believe they still, deserve to be diverted and deserve a different response than incarceration. So just that communication strategy is super important in getting people on the same page in your community.
Thanks, Kristen. I can remember from my work being, a prosecutor is you only get one bite of the apple. And, I think, now we're seeing, just like what you said, like sometimes it's going to take many, many tries, for someone to hopefully stabilize. So appreciate that. So just one final for each of the sites. And again, I think some of you have spoke to this. If I had to answer, I heard a lot today about housing needs, data integration needs, and of course, our workforce shortage crisis, is just so much at the top of the list. But what is your one wish for this population, the familiar faces? What would be your one wish if, you budget wasn't a concern, staffing wasn't a concern? So I don't know who wants to take that one.
I can start, Lisa. I think, if budget wasn't a concern, we would most definitely go full charge at the workforce. But I think, in my mind, really the next best thing is really kind of addressing stigma, right? Both stigma about those living with behavioral health needs and substance use disorders, but also the stigma of accessing treatment, right? Like just kind of the stigma of actually being receptive to treatment and care. Because many of our familiar faces have been, have attempted to access care and then, met red flags and told they didn't qualify. And so they lose that trust and there's a stigma associated there. So taking stigma a little bit deeper to ensure folks have the ability and capacity to access those spaces and feel comfortable to do that.
Thanks. Anyone else want to share a wish?
I mean, I guess if we're talking about wishes,
It's wishes.
So just thinking about, just a shift in the way the community thinks about crime and we talk a lot about just like redefining public safety. Like, what does that mean? Having a holistic approach to that. And I think that, applies to our familiar faces. So just very broadly, just humanizing people, right? And just creating as many alternatives to law enforcement responses as possible. So we can just keep shifting it, further back into the community where, services belong. So I guess that'd be my kind of wish. Yeah.
Thanks, Kristen.
You're welcome.
Anyone else wish to share a wish? Nick?
Sure. My wish would be for every service provider and program to use a standardized like case management software, because dealing with different agencies that all use different software that's set up very differently it's tough, and it makes the kind of data integration that we want to do so much harder.
Thanks, Nick. Certainly expected an IT related wish from you. So, anyone else? I don't want to force this, but anybody else want to close out with a wish?
And Teresa, if we have 3 wishes.
Oh, you may have
more.
Okay, sure.
And I think this is consistent for everyone, really is like housing, right? I think everywhere we talk about housing and the need for housing, and above and beyond just locations, right? Like apartment complexes, but actually supportive housing so that people can be successful, especially our familiar faces, right? They need that wraparound, that continued supports to be successful in housing and to be able to maintain that long term.
All right, thanks you all. We're definitely at time here. I know that there's been a few questions come in on the chat. We have contact information that I know you want to reach out directly to any of our panelists today that they'd be happy to answer you. And Mark, anything else in closing today?
Yeah, just reiterating that the panelist contact information is here on this slide and they'd be happy to follow up. Definitely wanted to thank everyone for your presentations and for the discussion today. And thank you to everyone listening in. We recorded this webinar and we should have the recording available within a week. So thanks so much, everyone, and have a great afternoon.
Thanks, everyone. Goodbye.
Thank you. Bye.